Consents are ubiquitous in medical practice. Today we will discuss consent types and their dangerous nuances. I am Dr. Neeraj. You took a consent but still lost a case because it was a blanket consent which is legally not valid and useless. Consent is not a form, it is an autonomy-driven legal doctrine grounded in patient's self-determination. Legally valid consent requires three things: capacity, decision-making capacity of the patient; disclosure, material risk, not just the common ones; comprehension, patient actually understands what you have said. Miss any of one, the consent becomes invalid even if it is signed by the patient. This landmark shift came from the Montgomery versus Lanarkshire Health Board. The standard moved from a reasonable doctor to a reasonable patient, meaning you must disclose material risk relevant to that patient, not just what the doctor thinks is important. Implied consent is what we get in OPD for examining the patients and vitals. Express or verbal written consent is for procedures and admissions. Informed consent is legally defensible document. Proxy consent is for minors and incapacitated or given by the next of kin. Emergency consent is a doctrine of necessity. It is life-saving and no delay can be taken by the doctor. But high risk, rare complications must be disclosed. Like a contrast anaphylaxis in a CT, nerve injury when a central line is being put. Courts don't care about probability. They care about the impact on the patient decision making. So always document this exact line. Procedure risk, common and serious ones, even if it is rare. Alternatives available for the patient and consequence of refusal. Explained in the patient's original language, mother tongue. Then patient-specific risk. For example, a diabetic is at a higher risk of infection from an invasive procedure. So this single sentence has saved more clinicians than any guideline. Consent is not just a signature at the end of the paper. It is a legal ICU ventilator when things really crash.